Hello, everyone. My name is Angela Clark with Propel a Cure, and we're here with another episode of our virtual discussions talking to leading researchers in IBD. And we're so pleased to have today Dr. Uma Mahadevan. She's not only going to talk about the management of pregnancy in IBD, but other related topics that are so important, like fertility, contraception, breastfeeding. And before we do that, I want to let you know also that much of the ground we're going to cover today is available at their excellent website at pianostudy.org. So you can go there afterwards and look at everything in your leisure. And with that, I'm going to review Dr. Mahadevan's bio with you before we delve into the questions. Dr. Uma Mahadevan is a gastroenterologist and clinical scientist specializing in inflammatory bowel disease and is a global expert on the management of pregnancy and drug safety in IBD patients. She is currently a professor of medicine at the University of California, San Francisco, where she is also a Landmark Benioff Professor of Gastroenterology, as well as director of the Colitis and Crohn's Disease Center there. She chaired the Global Consensus Statement on the Management of Pregnancy and Inflammatory Bowel Disease Project and is the principal investigator of the PIANO study, which stands for Pregnancy in IBD and Neonatal Outcomes. Dr. Mahadevan completed her medical degree at the State University of New York in Brooklyn and a residency in internal medicine at Mount Sinai Center in New York. She also completed a fellowship in gastroenterology at the University of California, San Francisco, as well as an IBD fellowship at the Mayo Clinic in Rochester, Minnesota. She has served as an editor and reviewer for many well-known medical journals, including as a special sections editor for the journal Gastroenterology, and has published numerous original articles, abstracts, editorials, and invited reviews. She has authored or co-authored over 100 studies across a spectrum of IBD topics. Dr. Mahadevan is a fellow of the American Gastroenterological Association, where she currently serves on the Digestive Disease Week Committee. In 2022, she was awarded the prestigious Sherman Prize. Welcome, Dr. Mahadevan.
Thank you so much, Angela, for having me and the lovely introduction.
We are so excited to get into some of these topics. I know the topic of pregnancy and IBD and all the other related subjects to that is of primary concern to a lot of women, those of us who have IBD or who have daughters or sisters or friends, and spouses and loved ones as well. So we're really looking forward to this and looking forward to our viewers learning more about this important topic. Now let's start with there are a couple of so many things actually, but a lot of us have heard of the PIANO study and the Global Census Statement on the Management of Pregnancy and Inflammatory Bowel Disease. And these are both very ambitious projects and studies that have drawn on truly global expertise and input. Can you explain the origins of these and why they're so unique?
Yeah, great. So let's start with PIANO. So the PIANO study was launched in 2007. It was initially funded by the Crohn's Colitis Foundation, and we used the Crohn's Colitis Foundation Clinical Research Alliance. So all these different institutions that were part of the CCF and were part of the Research Alliance, and we had over 30 sites, and we were interested in understanding the safety of medications used for IBD in pregnancy. So if you think back to 2007, we were still wondering if thiopurines were safe. We had very little data about infliximab. And so this registry started as a prospective registry. So we enrolled pregnant women, followed them out to a year. And then the question arose, well, what happens after a year? So we extended to 4 years. And then we said, okay, well, what happens after that? And so now we follow the children out to 18 years, and we have about 2,400 women who have participated, and we continue to enroll because every year there's a new medication and there's more safety concern that we need to address. And we looked at risk of birth defects. We looked at breastfeeding. We looked at placental transfer, response to vaccines, infections, cancers, all of these things in PIANO. And that has been great to have this resource and infrastructure to look at every single drug as it comes out. But what happened is we had this data and we very clearly saw that women with IBD If they had active disease, that was the biggest risk factor for infertility and for miscarriage and for adverse outcomes to the infant. But because there's so much fear that goes into treating women who are pregnant, the default was just to stop their medications. Often these women would flare, often they couldn't go back on the same medication that was helping them. They'd have complicated pregnancies, sometimes lose their pregnancies. And we strongly felt that there needed to be one voice on this. Different countries, different journals would come out with their own guidelines. They would vary, and that would confuse people, the providers, the patients, etc. So we felt we had enough data to really come out with one statement. And this is very rare in medicine and rare in gastroenterology. I think the only other one is maybe during COVID, but we took experts from every continent. We had 39 experts, plus patient advocates, plus specialists in teratology, lactation, surgery, et cetera, come together, review all the data, and come out with one document that everyone, everywhere should use on how to manage this population. You really have 9 months to get it right. And it's such an important thing for patients. So that's where Piano provided data along with multiple other places in Europe and Australia, et cetera. And then the global consensus sort of put it all together with global expertise to come out with one set of recommendations that everyone universally can follow.
That's great, because I remember seeing your findings, your group's findings come out, and really, I think as a family member of one with IBD, that had been, and as someone trying to follow the literature as a layperson, we hadn't seen a whole lot of that. And just to be able to have a consensus, not only I think for patients, but it's for providers as well, right? Is that correct? Yeah.
Correct.
Yeah.
The consensus is primarily for the person taking care of the patient, the obstetrician, the gastroenterologist, whoever else is involved in their care. But it's written in such a way, and we've translated it in a patient video so that patients can easily look at it or look at the video and catch all the highlights and have access to the actual paper to share with their provider in case they haven't seen it.
Wonderful. Well, let's start with, and you all made some recommendations and best practices concerning contraception. I know there are a lot of questions around that for patients, and hormonal, non-hormonal. There's choices out there, and what is considered best for the IBD patient needing to use that?
So the best is actually the same as for all women. So LARC, or long-acting reversible contraception, is considered the most effective. People take contraception to not get pregnant. If you use a IUD or a progesterone implant, you take away human error, so you don't forget to take the pill. You also, for patients with IBD, don't have to worry about whether you're absorbing the medicine or not, or whether something you're taking like an antibiotic is interfering. So for our patients with IBD, for preventing pregnancy, IUDs and progesterone implants are the most effective. For avoiding blood clots, which are increased in patients with IBD, particularly those on a JAK inhibitor like upadacitinib or tofacitinib. And also it remains, as I said, no issues with absorption for these patients.
Now, does IBD, you mentioned earlier, how does it impact the fertility of patients? Does it, and if so, how?
It does impact fertility in many ways. One way is if you have active disease, you're less likely to be able to conceive and more likely to have a miscarriage. So being in remission when you try to get pregnant is very important. The second thing is if you have had surgery in your pelvis, you may have scar tissue around your ovaries, your fallopian tubes, and this may impact your ability to conceive on your own. The third thing is, and this data is not as well fleshed out, but it looks like women with IBD may have lower ovarian reserve. So when you go in for fertility testing, they check something called anti-Müllerian hormone that tells you how many eggs you have, essentially. And for women with IBD, that seems to be lower than age-matched controls, and it does seem to be impacted with how severe your disease was. And so one of the conversations I have with my patients is that if you really want to have children, and you're in a position in your life to do so. This is not something to delay until you've traveled the world and done all these other things. It may be much harder the older you get, and that's true for everyone.
Interesting. Now, what about, is there any impact at all? I know a lot of IBD patients go through um, a lot of imaging type procedures. Does that have any impact on fertility or not? What have you all seen?
No, there's no evidence that having scans, and we usually do more MREs, but CT scans, MREs impact fertility.
Do you have any special advice to those? Well, you just gave some, I know. Any other advice for those planning pregnancy? What should they do before they start trying?
I think the most important thing is to do preconception checklists, to check in with your obstetrician, make sure your vaccines are up to date, make sure your pap smear is good, because women may have higher rates of abnormal paps, which can impact fertility. Check in with your gastroenterologist, make sure you're in remission, make sure the medications you're on are compatible with pregnancy. And once you are in that space and you've stopped smoking and you're not drinking and you're taking away the opioids, all those things that everyone should do, that is a good time to consider conception.
One concern that IBD patients have is passing their disease to their child. Do we know some of the things that elevate that risk? And is there anything that can be done to minimize it?
So patients who have children, I should say children who have a first degree relative, so a sibling, a parent with IBD are more likely to have IBD. So there is a genetic risk. It does appear to be higher with Crohn's disease and ulcerative colitis, but even then the risk is about 2 to 4%. Now, if both parents have IBD, that risk can be as high as 30%. And there are certainly some families where there are multiple relatives, first and second degree with IBD, and those risks are higher. But in the average patient with IBD, the majority of them don't have an immediate family member with IBD. If the mother has IBD, it's about a 2 to 4% risk of passing it on to the child. Now, some very interesting data we talked about in the global consensus out of Asia from Professor Suang suggests the use of antibiotics may increase the risk of IBD, and consuming food additives during pregnancy may increase the risk of IBD in the child. So one of the, antibiotics, if you need them, you use them, but avoid unnecessary antibiotics and really try to avoid food additives and ultra-processed foods during pregnancy.
And I wanted to ask, have there been studies or there studies planned? These seem to have been focused on women for the most part. Am I right? Is there anything in the future that might look at male IBD patients in more depth in these areas?
Yes. So there are some studies that look at male fertility. I think one of the issues with male fertility is it truly is that moment of conception. For the mother, it's conception, it's carrying the baby, it's lactation. So there are a lot more factors. We do know that sulfasalazine can give poor sperm quality for men. So if they're on sulfasalazine, they should switch to something else. Methotrexate, which is contraindicated in women because it can cause birth defects, does not seem to have the same effect in men, but it does reduce sperm count. And then disease activity can also reduce sperm count and sperm quality in men. So that is the data that we have so far. So for men, it's really a question of fertility. The other drugs do not seem to impact fertility.
Okay, well, that's good. From what you all have found, and you alluded to this, IBD mothers face a higher risk of complications during pregnancy, regardless of whether their disease is active, which is interesting. Can you share what some of these risks are?
Yeah, absolutely. So definitely if you have active disease, you're almost 3 times more likely to have a complication than if you have inactive disease. So disease activity is very, very important. But compared to the general population, a woman who is in symptomatic remission in pregnancy, which is how most of the studies were done because they weren't scoping pregnant women. So if a patient was in symptomatic remission, they still have an increased risk of miscarriage, preterm birth, complications of labor and delivery, including preeclampsia. And so we are seeing that. And I think our understanding of that is evolving. And one of the studies we're doing at UCSF with Susan Fisher's lab is studying the placenta. The placenta is a highly immunologic organ. And what we're seeing is that among women with IBD, the placenta does not look the same as what you would expect in a person without IBD of the same age who delivers. And some of those changes may be what's driving this.
Can you talk about what some of those changes or what that looks like to you as a provider?
It's something that you see in the lab. So we collect placentas immediately after birth and process them and look at them. And they're just a lot, I think visually you could just see there's just a lot more empty space in the placentas of patients with IBD, a lot more abnormality. The placentas may be smaller, may be malformed, even in patients who were on a medication, who went through their whole pregnancy in remission. And that has to do with the fact that the placenta has so many cytokines and is such an immune-related organ that the changes in a patient with IBD is affecting that. And that's true for all immune diseases. So if you look at rheumatoid arthritis, they have the same risk of preterm birth, small for gestational age, et cetera. And a lot of that is probably driven by placental changes.
So preterm birth is one of the risks of that placental abnormality. What would the others be?
It can be. And the others are placenta accreta, preeclampsia, placenta previa, all these abnormalities of the placenta that we see in patients with IBD, but they're rare enough that you don't see a lot. We do see increased preeclampsia in patients with IBD compared to the general population.
Some really fascinating insights there. The piano study has provided, that we've talked about, has provided a lot of detailed information and much of it encouraging regarding the use of medications during pregnancy. And you touched on that as well, and there's a lot to unpack. But could you provide just a few highlights of what you found about the continuation of most of the medications during pregnancy and any effects on the fetus?
Sure. So I think this again goes back to the placenta because we have two types of medication. We have monoclonal antibodies or biologics, medicines like infliximab, risankizumab, ustekinumab, and then we have small molecules, medicines like azathioprine or upadacitinib or the S1Ps. And when you look at the placenta and you look at how the baby's organs form, the bulk of organogenesis is between weeks, 2 through 8 and in the first trimester. So if you have exposure to a drug in the first trimester, you're more likely to have a birth defect because that's when key organogenesis occurs. Not all of it, but key parts of it. The biologics like infliximab are too big to just cross the placenta on their own. Beginning around week 14, the placenta develops a receptor called the FcRn, and that starts actively pulling antibody across the placenta. So by the third trimester, that's when 80% of the transfer of antibodies occur. The reason the body does this is how they pull antibodies to protect against infection from mother to baby. So it's a protective mechanism. So those antibodies against infections are transferred primarily in the third trimester because we're also giving antibody, those cross. So while you're unlikely to have birth defects from a biologic because there's no exposure in the first trimester, you will have transfer across the placenta. So for infliximab, that has the highest transfer, and the ratios in the baby are 3 to 4 times that of the mother at the time of birth. But the newer biologics like risankizumab, they're different epitopes. They don't bind the FcRn the same way, and they have much lower transfer. But reassuringly, when we look at the infants out to 1 year, out to 4 years, there's no increased risk of infection or cancer seen in these kids. So even though they have that antibody, it doesn't seem to be causing any significant issues for the child. So if a new biologic comes out, or for our current biologics, the recommendation is to continue them throughout pregnancy and breastfeeding because almost nothing transfers in breast milk. However, with a small molecule like upadacitinib, it will cross the placenta in the first trimester, and so there is a risk of birth defects. And in animal studies, birth defects were seen in animals at the same doses we use in humans. Now, thiopurines like azathioprine 6-MP cross the placenta as well. And the birth defects in animals were at super therapeutic doses, so at like 10 or 15 times the dose in humans. And so I think that's how we want to frame how to look at a drug. So if it's a monoclonal antibody, whether it's a biosimilar, a biologic like infliximab we've had since 1998, or gazolcamab, which just came out last week or last year, those can be continued in pregnancy to keep the mother in remission because we don't think there'll be birth defects. Now, we have to study them to make sure there isn't anything else, but it's reassuring. Small molecules like upadacitinib, there's more concern, and we really only use that if there's no other option for the mother. We try to find something else.
Good to know. Now, what's the best way to monitor disease activity in patients during pregnancy? Can they still do scopes? What about some of the other imaging methods?
We really try to avoid scopes in pregnancy unless it's going to change the management. So if a patient has a flare and you need to know what medicines you're going to use, we will do a flex sig in pregnancy without medication. But in general, we don't do scopes and rarely need to do them. Intestinal ultrasound, if you have it, is probably the best way to monitor um, disease activity in pregnancy. In the third trimester, it's hard to see. So it's a better exam in the first and second trimester. And a recent study in gastroenterology, I think by the Australian group and others, showed that if you have abnormal intestinal ultrasound findings, even if the patient's asymptomatic, they may have more complications. So it seems like it's an important tool. And then stool calprotectin is important as well. But it's important to remember that sedimentation rate, hemoglobin, albumin, things that we often use to see if people are in flare are very abnormal in pregnancy. So you can't count on those.
Are there any other additional medications or are that pregnant patient IBD patients could take during pregnancy to help them that you have found out about?
Absolutely. So, of course, everyone should be on a prenatal vitamin with iron. That's all pregnant women. But another key finding of the global consensus was a recommendation to take baby aspirin throughout pregnancy. And so this recommendation comes from the ASPRE, ASPRE study out of Australia, which took women who were at risk for preeclampsia and randomized them to get aspirin at 150 milligrams a day or not. And the ones that got aspirin had lower rates of preeclampsia. Since women with IBD are at increased risk for preterm preeclampsia, we do recommend they start baby aspirin between weeks 12 to 16. So you have to start by week 16 for it really to be effective. We recommend they take it with food. And because 150 was a dose used in the study, we used 2 baby aspirins, so 281 milligrams, so 162 milligrams. And they continue it throughout pregnancy. Sometimes the OB may stop at the end of week 36 because you're no longer at risk for preterm preeclampsia. And but that is an important recommendation. Studies from UCSF and Mount Sinai have shown that there's no increase in flares to these women who are taking this aspirin during pregnancy.
Is there a consensus on whether vaginal delivery or C-sections are best for the pregnant IBD patient?
For the most part, we really leave that decision to the obstetrician and the patient. The only time we as gastroenterologists would step in and say this patient really needs a C-section is if they have active perianal disease at the time of delivery, or if they have a current or past rectovaginal fistula. Rectovaginal fistulas are very, very hard to treat and to close. For patients with an ileoanal J pouch, that really comes down to shared patient decision making. In our center, we do recommend that these patients get a C-section at a facility that has backup surgery. The reason for that is we think that pelvic floor function gets worse with vaginal delivery in these patients, and it can impact continence and other issues down the line.
Is it okay for IBD mothers to breastfeed? Does the medication pass through the breast milk to the infant?
So this is another place where we like to use science. And there's something called the relative infant dose, which is the amount of drug that goes to the baby compared to the levels in the mother. And a level less than 10% is considered acceptable. So when you look at biologics or monoclonal antibodies, we have our friend, the FcRn again. And so when a mother takes a biologic and breastfeeds, the amount that eventually gets into the baby crosses the breast milk is low. And then the baby has to take it in, and then it gets broken down in the GI tract, and the amount that crosses into the baby's blood is about 0.01%, so extremely low levels. So we have no issues with breastfeeding on a biologic because almost nothing gets to the infant. However, if you take a medicine like upadacitinib or tofacitinib, these are small molecules. They will passively cross. And in one study, it looked like the amount of tofacitinib was higher in the breast milk than in the mother's milk because of the gradient. Even though the relative infant dose was less than 10%, it was more like 5%, we still recommend that patients avoid breastfeeding on the JAK inhibitors. Thiopurines are fine, corticosteroids are fine, mesalamine's fine.
Now, on the site we refer to that is out there, pianostudy.org, there is so much information on that. So let's go through that a little bit. One thing is the ability for women to enroll in the piano study, which is still ongoing. So they can actually register there. Is that right?
That's right. And we would love for any US-based patients who are interested and who are pregnant to reach out to us. It's very easy. It's questionnaire-based that you do online. And then we get a sample from your cord blood and from you, the mother, not the baby, on the day of birth to let us know how much drug is in the system. And we correlate that with risk of infection. And fortunately, it found none. And so you can enroll remotely. You also can see how many patients with IBD are enrolled in piano on whatever drug you are on. So that updates in real time. So we have 15 patients on upadacitinib. We have 600 patients on infliximab. And so you can look at that. Every paper we published is on there, along with a brief synopsis of this. And most importantly, I would say, is the patient video from the Global Consensus, which is a 7-minute video in 7 different languages that really goes through everything you need to know about pregnancy and IBD, and also has information for you to share with your provider. Every woman with IBD should be followed as high risk, because even if you're young and you're otherwise healthy and in remission, your risk is higher than the average patient. And high risk means different things in different places, which is one of the things I learned from the global consensus, that resources are different in different parts of the world, and in fact, in different parts of the US. At UCSF, we send our patients to a maternal fetal medicine specialist, which is a high-risk obstetrician. In other places, they may have midwives, and the midwives just need to know that these patients need extra monitoring.
And I have to attest that your site is just wonderful. There's a slide deck to that as well. And how many languages, just multiple languages that are available on that site as well, I think, right?
Yes, the slide deck is in English and Spanish. Most of the other languages, we actually looked, most of the physicians in those countries learn in English, and so we didn't need to do that. But for patients, it's English, Spanish, French, Portuguese, Chinese, Arabic, and Hindi.
So once again, I encourage everyone to go to, we'll show this up on the screen as well, pianostudy.org, and it will just give you awesome detail of everything we've gone over today and much more. And we want to thank again Dr. Uma Mahadevan for talking about this important subject, for giving us reassurance and clarity to the issue of pregnancy and all those topics surrounding it. Thank you again.
Thank you for having me.